Well, good afternoon, everyone. I am really excited to spend some time with you and talk about the CRA's role in risk-based monitoring and some strategies for effective remote monitoring. To tell you a little bit about myself, I am a registered quality assurance professional in good clinical practices. That means that I have been in QA for a very long time and I'm certified as an auditor there. I started off in the industry about 21 years ago, and I've worked in clinical operations and quality. So a lot of experience in inspections and in the current regulatory landscape. I'm excited to be able to share that with you guys today as we talk about this topic. So what are our learning objectives for today? Well, we're going to describe approaches and techniques for remote data review. So how do we do this? We're going to explain techniques for query writing to ensure that clear communication of issues is ongoing. And we're going to implement strategies to identify problem areas and how to maximize time on site if you are doing some remote monitoring. And really, we all want to save time and money without compromising oversight or quality. And these can be an ongoing challenge for us in the industry. Here we are in an age where technology is ever present, from being able to order medications online, consult with a physician, have live conversations in chat rooms about medical industries, or about medical issues, and our part of the industry has lagged behind a little bit in this. And I don't know how many of you there are a few of them, but I'm just going to name, talk about one a little bit. There's a particular app that you can download to your smartphone or tablet or whatever, and if you have an issue, you can click on that and be connected to a doctor no matter what time of day it is, and you can talk to them about your issues, and they can even give you a little bit of an exam over the video chat piece, which is really exciting. And my first experience with that was while I was traveling for work, and I was in Chicago. I'm local to North Carolina, so I was a ways from home, and I got food poisoning. And oh my goodness, I thought that it was going to be the end of the world. And I needed to see a doctor, but I definitely was not in a condition to drive anywhere. I didn't have a car with me. And so I used an app like that, and I was able to connect up with a doctor. We were able to get, because of course it was midnight, because that's when these things happen, a 24-hour pharmacy, and a very nice Uber driver actually went and picked up my prescription for me and brought it to my hotel. So technology is out there, and it's already being used in a variety of ways in medicine already. And we want to be able to appropriately leverage those things in the research setting. So we want to talk about one of the ways that we can use technology to our advantage, and some of that is done in risk-based monitoring and in some of the approaches that we have based on the systems that are now available to us. So here's a little cartoon, and what it says is the computer says I need to upgrade my brain to be compatible with its new software. And I know that sometimes we all feel this way with the advent of systems. And for those of you who are CRAs and have been on site, you may have been handed a flash drive to look at essential documents, or you may be video conferencing in with the PI to do your interview. There's a lot of different things these days that go on, and sometimes it can make our heads spin, and sometimes it can seem very overwhelming. But really, it's not, and there are ways to distill it down and make it a little bit easier for us. And back in the day, we did 100% source data verification. We checked every single data point, and now we're going to look at risk in order to determine what do we need to look at and how much of it do we need to look at and how often. So what are our current practices? Well, there's all kinds of them. Sometimes we have periodic, frequent visits with 100% SDV. So you may go out every 2 weeks, 4 weeks, 6 weeks, 8 weeks, 10 weeks, depends on your study, and take a look at everything and look at all the things that you didn't look at from the last time that you were out there. It's really a reactive sort of approach and premised on retrospective detection of errors. So you're not seeing them before they happen or as they happen. You're seeing things after they happen because you're going out to look at it. And the oversight efforts might not be commensurate with risk. So you either may be going out too much or too little, depending on the risk itself. It might not optimally address significant risks to the trial. So we may be missing something, or we're doing overkill in an area. And it really can tax our resources. It can be really challenging. It takes a lot of people to go out and do 100% SCV, right? You can't look at as much if you have to look at every data point. And if you've worked on some very complex clinical trials, and you also know that there are some very complex data points and lots of them. And you got a lot to look at if you're doing 100% SCD, right? And CRAs are often overly burdened in the travel arena, and I know many CRAs have told me over the year they can barely keep a plant alive because they're not home very much. And so a lot of them have cactuses, ironically, but they don't necessarily have the time to work with the sites to help the sites optimize.